All right, welcome everyone. I'm here with Kathy Couch, and we're going to talk about grief processes in EMDR. Welcome. So, um, it's only been in the last few months that the term thanatology, did I even say that correct? Thanatology's been in my vocabulary. If you don't mind, tell us a little bit. Tell us a little bit about it. What is it?
Well, I'll kind of just start by maybe giving a little bit of background of my personal journey in the field. So I'm something called a certified thanatologist. And what happened is I was treating patients at a substance abuse clinic, and I just felt like there was something that was missing. And I really connected with people that were experiencing grief. I had volunteered with an organization in my town called Because Kids Grieve, where we help kids who are grieving connect with activities and peers and do activities to support them. And so I began researching through that organization. There was somebody who was a certified thanatologist. And so I thought, well, what is that? I've never heard the term. And I knew that he was a part of the grief community that I was in. And so I went to the Association of Death Education and Counseling. I went to their site, and there's this certification in thanatology. And so what that is it's a certification in death, dying, and bereavement. And they have 6 categories and 10 indicators that are considered fundamental to the skills of death, dying, and bereavement. So dying, end of life decision making, loss, grief, and mourning, assessment and intervention, which is like for caregivers, traumatic death, and then death education. So you have those categories, which made sense to me. And then you have these indicators, which are basically illustrative of topics considered to be probable when dealing with those categories. So I was just fascinated, and it's a really extensive exam. They do it once a year, maybe twice now. And so they have this book that you have to study called the Handbook of Thanatology, in addition to probably 4 or 5 other books.
Wow.
And it's quite a rigorous test, one of the most extensive tests I've done, even a little bit more difficult than my licensing exam. So that's thanatology as far as it has a body of knowledge that you kind of work in. And then you have 2 certifications. You're a certified thanatologist, or a FT, which is a fellow, and thanatologist, which is you teach in the field of thanatology. So you kind of, to get the certification, you have to look at those categories and kind of have some general understanding about those. How
Okay.
did you hear about it? Tell me about how you.
I believe I ran across it. I'm not entirely sure where I ran across it, but I remember running it across maybe 6 months ago. But I knew that it was loosely associated with grief when you mentioned it in our work that we've done together. So I'm looking forward to learning more. So how does this, it sounds like this approach to death and dying has a framework, right? It
Yes.
has a kind of theoretical understanding. And I do love what you said, that these are the kinds of things you might expect to come up. They may be probable, or they may be kind of themes, but how does that really inform clinical work or help shape clinical work related to grief or loss or
So
bereavement?
so you have those categories, and then you have the indicators. So when we're talking about these, we're talking about 2 different things when I'm talking about theoretical frameworks or the body of knowledge from the Association of Death Education and Counseling. So the body of knowledge is categories and indicators. The theoretical frameworks, which we'll talk about here in a minute, are really beginning with Freud and talking about how that theory of how we work with grievers has developed clinically. So there's kind of 2 different aspects we want to delineate with. But what I'm doing is, when I found, when I was doing this, EMDR, trying to become a consultant, they say, what is your specialty? And I really had to think for a minute, what is my specialty? Like that disillusionment sometimes that we feel like, I don't know who I
Right.
am. I've
And you
been.
literally had a specialty.
I know, I literally had a specialty, right? And so it was like you were derealization, like, I don't know what I just did. And so then I was like, oh, I mean, intersect both of these beautifully. And so that's what I'm doing in my upcoming training, is helping people identify a target from these categories and indicators with EMDR. So let's say as EMDR providers, we are able to understand topics that might be considered probable when dealing with a patient. What we're doing here, let's just use the concept of, let's do traumatic death, because that might be more of what we deal with. We'll learn about different causes of death. How do people make meaning out of it? We'll really dive in and kind of go into the minutia of it. Look at the attitudes, the gender, the cultural factors. So when we're looking at an EMDR target and somebody comes and says, my son was just killed, help me here, we can really kind of dive in to the lifespan issues, institutional or societal issues, family, individual, resources, research, ethical issues. Those are some of the indicators around it, so we can get a little bit more defined target and create a more targeted sequence plan. What's that? Targeted sequence plan?
Sure.
So that's what the training is about, is really marrying these two so that we can kind of get a little bit better target.
When we think about grief, we think of it as something that kind of happens to you.
Mm-hmm.
And when we work on it, we're going to just work on it however we work on it. But it sounds like you're suggesting that there may be a lot of wisdom in having a structure and a way of kind of approaching this. From the fact that people have been thinking about death and dying for a long time, may have actually had some pretty good thoughts and ideas about it that may help us do this work more efficiently. And
I want to talk a little bit about now that we have that part complete, a little bit about maybe the progression of the theory. What I'm saying here is, when I'm teaching people about this, it's really this beautiful intersection of, once I understand my theory, and I understand my patient's theory, we can kind of really avoid some of that interview and just kind of really understand the basic beliefs of their system without having to kind of assess it right with different tools. So I'm developing a toolkit where we can kind of help just get into the beliefs about a traumatic death or these kinds of things, so that we can have that toolkit available for people, from the assessment to the treatment planning. My background before, all this was research and evaluation. And I taught at Boise State for 10 years. And so I really took those research and evaluation tools and help us think about and conceptualize this case conceptualization, how to assess and identify the targets, right? And so when we think about how we call it modern grief theory, if you ever want to learn more about grief, there's this wonderful website, whatsyourgrief.com. It's run by Eleanor Haley and Blitza Williams, I believe. And they were out here in Idaho for one of our conferences one year. It was during the pandemic, so I didn't get to actually meet them, darn it. But they developed a program that I went to that talked about various modern grief theories. And so when we think about how it developed, really the idea came from Freud, where he began this idea that grief was an act and natural consequence and result to loss, but it was final. So those who are grieving, you just need to confront it and get over it, basically. And that's where it began. And so really the mourner was really to just dissect and emancipate themselves from this emotional bondage of the deceased. It's done, it's over, why are you worrying about it? Right? But it began the conversation for us, and as we kind of moved forward, we moved into this framework where Eric Lindemann, he kind of developed this part where we're able to research distress, where we're emancipating, and then he took it to a couple other levels that Freud didn't. Readjustment to a new environment, which the deceased is missing, right? My dog passed away. How do I come home and call his name subconsciously? That's stressful, right? And then form a new relationship with a new pet. How do you do that? How do you move forward with this new sense of self? So I have a patient who found his girlfriend dead in the home during the pandemic. And so it's that clinical themes. When we think about these things, we think about the 4 clinical themes: safety, responsibility, effectiveness, and control. And I've been thinking about this, and really when we're working with a griever, the power and control and sense of responsibility are the two more dominant clinical themes, right? If I could have done something, that responsibility towards self, or, that power and control, I wasn't there for this
Right.
idea. So
Yeah.
Lindemann came and kind of moved this forward. I'll kind of do this pretty quickly. And then we have the Kubler-Ross stages, which we're most familiar with when we say, what's the framework? We believe, I think, beginning, we've said, okay, here's the 5 stages. It was seen as linear. There wasn't any fluidity. I think now we think there's some fluidity. And then we went into Warden and Rando. So actually, John Bowlby, the attachment theorist that we love as therapists, they assessed the children in mourning. And he really kind of made the shift from Freud to be able to look at this as a phase of observation and theories on attachment. So this is the first place we kind of see the shift to attachment wounds versus like this. Does that make sense?
It does.
So
And
for us
again,
as therapists,
yeah,
like this is the glue, right?
attachments where it's all at.
Right?
That's where
This is the
everything's at.
glue,
Yeah.
right? It makes me so happy. It's like, yes, we're moving forward, we're advancing. And then we have we went back to a task model with William Warden, who said there are 4 tasks one must accomplish: accepting the reality of the loss, working through the pain and grief, adjusting to an environment where they're missing. So a little bit of a variation on a theme. And then finding connection with the deceased while embarking on a new life. So then we're looking forward now, more than just staying in that linear moment. We're looking forward to a life without the deceased and more accepting of them as a departed person. And then Roger Solomon actually is one of the persons in our field that wrote about EMDR and grief. He's doing some workshops on EMDR and grief, and he posits in his article that we should have a clinical framework to understand grief. And so he uses the Therese Rando 6 R's of mourning. And so I agree with that, but I also agree that there's other ones that you yourself as a therapist want to understand about yourself and understand about the patient. And that's really what this evaluation and toolkit is to understand what are our beliefs about death and dying, how do they intersect with the patient, and what's this dynamic, because not everybody's framework is the same, right?
Can you say a little bit more about that? Because there aren't many frameworks that I'm aware of that involve the exploration of the therapist view of something in comparison with the client's view of something.
That just came to me. That's a divine download.
Well, it's awesome. I think that level of assessment is pretty interesting and novel. Is that, of course, clients come from a point of view, we come from a point of view, and assessing where we are and assessing where they are can
Think
be
about
pretty
that.
helpful.
If you believe that death is final and a patient is coming to you saying they're making a connection with the departed and searching for meaning, what's that relationship going to be like?
Right. Exactly.
So you're going to understand your culture of your microcosm within the macrocosm, right? You're understanding this dynamic. Maybe this isn't a good fit, or can you adjust your views about death to be able to treat the patient? So when we're working on some of these processes, Therese Rando kind of says you recognize it, you confront it, you react, recollect, relinquish, readjust, and reinvest. So we see a lot of this kind of reinvestment now coming forward. I think he does a beautiful job, Roger Solomon, of talking about this and sequence planning, but we don't think about it. We just kind of sometimes think this patient's coming in from a traumatic death. That must be the target.
Right.
Right.
Absolutely. And again, I don't want to stay too long here, but one of the places I think people really do get harmed in doing trauma work around grief is when a therapist has a view of the death and dying process that is profoundly at odds with the clients, because there may be therapists who in their own spiritual universes may have ways of completely making sense of this, which may inadvertently or not, project some defectiveness on a client that doesn't have that view, right?
And
So I've heard,
didn't we see that magnified in the pandemic, though?
right.
right. That's been just at the forefront of a lot of death recently in our society through the pandemic, of those intersecting views of like, I couldn't go see my mom in the hospital when she passed away. It doesn't matter. You don't need to see her. She was sick.
Right. And even though you literally couldn't have gone to see your mom, the guilt, shame, blame, responsibility, and it's so much what I see in grief work with my clients is guilt, shame, blame, responsibility are just so sticky sometimes when it
Yeah. So
comes
looking
to
at,
loss.
yeah, right. And the target, we want to be able to figure out what's an okay place to start. I'm not saying that
Yeah.
these 10 indicators, you have to go in and look at the minutia, but have a general idea of the park. You're going to a park, where's the play set kind of thing.
Right.
Um, and I want to kind of hit on these other
Sure.
few theories. So this is more of a theory that I kind of think about. So the dual process model of coping. So you have a loss oriented way of coping where it's the positive event, but you have negative beliefs, ruminations, goals, maybe this loss of things that have happened versus the restoration, that you can create a positive meaning and appraise this event with a positive culture. And you kind of go back and forth like this, I'm in this loss, but I'm also in this restoration. These are the things that have shifted for the better. So that's a dual process, which I
Hmm.
like.
Yeah.
And so that's sort of where of course, bilateral, right?
Yeah.
um, and then there's a continuing bonds theory. And so that is where we're shifting more. And how do you now go Silverman and Class kind of introduce this? And then now David Kessler with his book, let me grab it off my shelf here, Finding Meaning. Um, he has developed now a sixth stage, which I think is beautiful,
Okay.
and adding to the Kubler-Ross stages. And so this is where we're able to now sort of posit this meaning-making kind of place. And then there is a post-traumatic growth component that is one of the last places in the
Hmm.
spectrum, that we go. But
Awesome.
I really like that continuing bonds and that relationship, because if you think of grief, one of the questions that we were talking about was, how is trauma different than grief? Really, in this work, it's more of the attachment wounds in the relationship, isn't it?
Yeah.
It's usually more of an attachment wound that we're dealing with in therapy. And so if we can kind
Exactly.
of think about that when we're doing EMDR, that can help us understand the patient.
Right. Excellent. And certainly the end of someone is an attachment, is an attachment rupture for
Mhm.
sure. Yeah. Okay. What are some common blocks or difficulties in doing grief work that you find?
Well, I think again, going back to our point of we have to understand our own belief system. Do we
Mhm.
feel like you can have a relationship with the part? Do we believe in the cultural norms that you're engaging in to celebrate? I remember I went to West Africa for a study abroad, and one of the culture, in the community, the way they mourn their dead is by wailing publicly. And so I didn't understand that. I didn't know it. To me, it was like, this lady is screaming for help.
Yeah.
And my professor very kindly looked at me and said, this is the way they mourn their dead. That was even way before I was in thanatology land or
Right.
anything. And so understanding where they're coming from is very critical, right? And dealing with the patient. You get a lot of resistance sometimes because of the intensity of the nervous system. People think they can do EMDR right away. Sometimes the brain can't, sometimes it's not ready. And we have to look really at the adaptive information that's on board already with the brain that we're dealing with. And so, when it talks about, grief work, one of the ideas was, what are some of the blocks and difficulties? It's really that sense of responsibility, usually around the attachment wound. I should have done something. I wasn't there. Should have, could have, would have. Really, that is a big theme of that personal power and control. And a lot of times there's guilt and loss for what didn't occur. And they have a sense of, what if this happened? Could I have changed this outcome? And then other clinical theme might vacillate to other times when they had different losses. So that complicates it, right? you've had 3 wives that have passed the same way and you're coming to see me, it's gonna be totally different than if you're a 21-year-old newly married person.
Yeah,
So that whole lifestyle assessment really comes into play when you look at the brain that's in front of you, doesn't it?
absolutely. Yeah, awesome. Awesome. Related, tying this to EMDR, one of my favorite kind of topics, and let me back up. I
Hmm.
think a lot of people, when they talk about grief in an EMDR context, a lot of the advice out there may not be very good, sensible advice.
Yeah.
And in the context of what we've been talking about, it may be advice that comes out of that particular person's worldview more than what we know about grief. So one of the points of controversy that as an EMDR consultant is I often hear people say, well, you can't do grief work within the first 3 months. Or you shouldn't do grief work within the first 3 months or the first 6 months or the first however long. So there's information out there that working with grief or loss, we have to kind of let people, somehow be out there doing whatever they're going to do in their nervous system for a certain amount of time before we're able, or it's wise for us to do work with that trauma. So,
What do I say about that? There's so much, right? What I say is that's perpetuating avoidance,
yeah,
right? That's what my first inclination is. In some cases where we're just afraid to touch it because of the wellspring of emotion, that abreaction, I think that may come of a place of wanting to really proceed delicately, right? What is their brain doing? Can they get that adaptive information? As you talk a lot of times in your podcast, are we going to
mhm,
catch a fish bigger than the boat? That really ties into that clinical assessment. And you say a lot in all of your work, can we just do one little piece?
mhm,
We don't have to do the whole event. And I think that's no different really than in this grief work, because what is grief? It's a series of emotions and thoughts related to an event. So if we can deconstruct even a little bit of that or kind of help the patient just stabilize, sometimes it is a lot of resourcing right in the beginning. Sometimes it's an expected death. So it doesn't mean the same thing as maybe a traumatic death or even the death of an older adult child versus the death of a young child or an infant, right? So kind of all those things interplay to create the death experience for the patient's brain so that we can figure out what is in the brain that needs targeted. And so I think that's what we do in EMDR,
excellent,
right?
excellent, excellent. And of course, I guess it's just always going to be perilous when death is something that many, many, many humans are phobic of themselves. And here we are,
Mhm.
um, often doing this work on a random Thursday morning with someone who may be in a really, really heightened place of distress. It can
Well,
be tough work. It's real stuff. It's not like perceived losses. These are like
yes.
these are real existential um losses and consequences, and your world being turned upside down. So
Yeah. And what I would say to that is you have as a therapist to be aware of your own losses, right?
and I would argue your own avoidance
Uh-huh. Your
of
own,
that existential, reality when
and this,
we're implicated in this, right? We're implicated in this because we're human and this life is short.
that's a great point. I mean, that's
Yeah,
well said, right? Because
yeah,
we all have these same reactions. Maybe you're treating a patient, you know, who had some of the similar experiences that you had.
yeah.
And can you deal with that? Oh, my grandma just passed. I really am not in a place to do that,
Okay.
and really
So,
having that ethical
yeah.
talk with your patient.
So I'm going to try to summarize some of the things
Like,
that we've talked about, and you jump in and let me know what we're missing. I think a lot of therapists aren't particularly trained in grief, and we just figure this out, right? We just kind
yeah,
of figure this out as best we can. And what you've said, which really does resonate, is that our our own biases may be relevant here and may let us miss things. And really smart people have been thinking about this issue for a long time, and there may be some sense in bringing more structure,
Mm.
right, and awareness to this process so that we can work with these clients more efficiently, right? Hopefully with a little bit more compassion,
Yeah.
and ultimately more effectively. So thank you for giving us this overview. Where can people learn more about this? Where can they learn more about you? And how can they participate in your upcoming, um,
Training.
hopefully are your credits lined up,
Yeah,
MDRIA
I
credits? Are
just
they
got it. It
pinned?
took me 2 days to get it approved through EMDR, which I couldn't believe. Uh,
Excellent.
so yeah, I have
Excellent.
a 6 credit training coming up September 15th. You can register on my website, www.rewired360.com. And we will have a virtual training from 9 to 4:30. I think that's a Friday. And what we're going to do there is give you some resources to be able to treat these patients, understand your theoretical frameworks, your timeline. And I think it was so fun to put together matching two of my favorite things and really knowing there wasn't information out there. So this has been a really fun thing to put together. And then I matched it with a toolkit where we can go in, assessing this type of patient, someone dealing with dying, traumatic death, grief, loss, and mourning, and so on, and be able to kind of conceptualize the case and create a treatment plan. So that will be available after the training as a toolkit. And then some other resources I'll include in the training are where can you get additional trainings. What'syourgrief.com is a very good place. The TAPS Institute works a lot with the military. I've got a lot of resources from there. If you work with children, the National Alliance for Grieving Children has thousands of resources. If you're looking for a grief center for children in your area, contact them, and they have a link that can kind of tell you where the trends are nationally for grief in your state, in your area. It's super cool.
Mhm.
And so nagc.com is awesome. Those are the top ones that I had. Of course, grief.com, David Kessler,
Yeah.
he did a bunch of webinars in the pandemic that were free. And if you're into grief yoga, there's Paul Deniston does a grief yoga certification, and that's been super cool. So
That is
those are some of
excellent.
my favorites.
And I'll put all those resources in the notes or comments as this is distributed places. I believe you also do grief focused EMDR consultation
Yeah,
groups. Where can people find you for that?
they can find it on my website again at
Okay.
rewired360.com. There's a link for me individually and for the groups. And it's really just kind of also a place to talk about what we as therapists experience working with people in grief, right? So it's a very transparent place to feel like, oh, that's a hard case, and to support each other in those hard cases because we don't get that a lot. And then we also have our consultation and certification programs where you can go through and get certified as a cohort, and versus doing that individually at the EMDR University program. So lots of
Awesome.
good stuff all on my
Awesome.
website.
Excellent. Good. Good. Anything else? Anything else you'd like to leave with us?
I think just remembering, that this is definitely difficult work. People refer to you, if you're an EMDR therapist, people say, oh, he does EMDR, give him all these cases. And then you go to the next level with the death and dying cases. So just be kind to yourself. Remember, it's okay to decline referrals and take breaks, and really just make sure you have a support with a space of professionals and people that you can go to and support you in this work, because it can be difficult.
Yeah. All right. Thank you.
Thank you, Tom, so much. It's been awesome.
All right. Awesome. Okay. Bye-bye.
Bye.